I'm very happy to give you an update on new antifungals. My name is Martin Hoenigl, and I'm associate professor at the Medical University of Graz in Austria. These are my conflicts of interest. So why do we need new antifungals? And there's really a number of reasons, and many of them are somehow also related to climate change. So here you see a summary from one of our recent publications focusing on the impact of climate change on the fungus and the human host. And what you can see here on the left side is basically that climate change and the warming and drier climate has a significant impact on the fungus, triggering development of dermatolerance, increased virulence, as well as dispersal, for example, via natural disasters and winds, and increasing of the geographic range. But of course, climate change has also an impact on the human host, specifically also via natural disasters. And all of this leads to consequences in the clinical context, with, for example, increasing resistance seen in Aspergillus species, new pathogens emerging, or the spread of endemic mycosis or natural disaster-related fungal outbreaks. So when we think about natural disasters, we know that within the last 2 decades, they have doubled in the number of occurrences compared to the 2 decades before. And there's really a number of ways how natural disasters can result in fungal diseases and fungal disease outbreaks. Um, Mechanisms include, for example, via traumatic injuries that occur during these natural disasters, but also dispersal via the wind, for example, after wildfires, where distant regions can be exposed to fungal pathogens, and after natural disasters, specifically flooding events, moldy wet houses. So, thinking about climate change and antifungal resistance, there are again a number of mechanisms outlined here that may trigger development of antifungal resistance caused by climate change. And of course, this has to do with, reactions to climate change and reactions to new, more virulent plant pathogens and increasing use of antifungals in agriculture. But there's also direct impacts of heat stress on pathogens that may lead to development of antifungal resistance. And specific examples, of course, that we are currently seeing is the increasing prevalence of antifungal resistance in mold, specifically a sole resistance in Aspergillus fumigatus, but also increasing resistance rates in other molds like Fusarium species. And some of that we can directly link to the increasing use of azoles in agriculture. The risk there is, of course, that with climate change, we need to use more and not less azoles, and also the plant pathogens are becoming sometimes resistant to azoles. So also in agriculture, we need fungicides, new fungicides with novel mechanism of action. And here, the danger is really that some of these new fungicides are very similar to the new antifungals that we are currently developing in humans. So specifically, this is true for Fosmanogepix and Olorofim, and I will talk about these two later. And it has already been shown, some of them are already used as antifungal, as fungicides in agriculture, that they can trigger cross-resistance. We're also living in times where the causative species of fungal infections is changing. This is particularly seen with invasive Candida infections, where we see generally over the years, and these are the ECMM studies across Europe over the last 3 decades. And what we can clearly see is a decrease of Candida albicans across Europe and increase of non-albicans Candida species that is occurring. And we are currently running, you see Candida 1 to Candida 3. Currently, just a quick shout out, we are running the ECMM Candida 4 study, which has an observation period that runs actually until end of September this year. And we still invite everybody here in this presentation to join us in this study and write an email to Stella Wolfgruber. There's a typo here. It's Wolfgruber. Please delete the S. Or write an email to me if you want to participate in this now worldwide study. So for Candida 4 is the first worldwide study that we are conducting. We have increasing resistance rates in Candida species, also in Candida parapsilosis, where we are in the unfortunate situation that there was a mutation that triggered not only resistance, but also increased basically fitness of the organism. So it was a beneficial mutation, and this is, of course, now spreading across the world, specifically in many countries like Turkey, but also Spain, Brazil, many other countries, and it will really come to other places as well. And we see that we have an increasing number now of outbreaks reported due caused by this fluconazole resistant Candida parapsilosis. And of course, importantly, we do also have new pathogens emerging, not only Candida auris, but also Candida orthopsilosis, Cryptococcus tetragati, or even Fusarium muse that are triggered by climate change factors, of course, also by factors of social determinants of health that may play a role, and other contributing factors. And many of them are resistant to different classes of antifungals that we currently have available. Candida auris, of course, the most prominent example that has now really spread across the world. Up to 2017, you see it was really a disease only occurring in some countries of the world, but we know today this has changed very much. And this is just a map of COVID-related Candida auris outbreaks, which really already shows how much this organism has spread. Before we talk about new antifungals, we have to emphasize that actually in fact, also old antifungals are not uniquely available across the world. So specifically, when thinking about low and middle income countries, it has to be emphasized that many of these old antifungals that are already around for 2 decades are still not available in low and middle income countries. And you see here basically a map of low and middle income countries where you can clearly see that, for example, liposomal amphotericin B may not be available, basically, or echinocandins may not be available. So basically, dark blue are the only countries where both liposomal amphotericin B and echinocandins are available, while in many other countries, basically, availability of some of one or two of both these classes is missing. So we are still facing challenges of availability of the old antifungals, and this is also true for the azoles, where we do have a significant number of countries that do only have access, for example, to fluconazole or itraconazole, but not to the modern mold-active azoles like voriconazole. So this is very important to emphasize, and definitely a major area that we need to work on in parallel with developing new antifungals. Let's focus now on the new antifungals that are currently in the pipeline or have just been approved for use. And basically, on the left side, you see a highlight of one of our review of antifungal agents that have also activity against molds, versus on the right side, it's mostly antifungal agents that are active against candida and yeasts. And I will go basically through many of them and discuss some details. Also here, you see the major new antifungals that we currently have available. This is from our review in Clinical Microbiology Reviews published last year. That's very extensive, about 50 pages, lots of figures, including this figure. And you see here the spectrum basically and some of the benefits. For example, opalconazole is a new inhaled azole with activity against filamentous fungi. It's basically, in terms of spectrum, classically a mold-active azole without specific activity against Mucorales species. And it has the focus of pulmonary aspergillosis. And due to the fact that it's inhaled and not resorbed, we can give very high dosages into the lung that are inhaled, have very high concentrations in the lung without any systemic drug-drug interactions or adverse events. Fosmanogepix, in contrast, has a little bit a very broad activity spectrum of activity against filamentous fungi, endemic fungi causing endemic mycosis, and also so dimorphic fungi, and also the yeast spectrum, where it's a very broadly active antifungal that's available as an oral and IV formulation that's currently developed in phase 3 trials. Olorofim Again, coming from a very broad spectrum antifungal of Fosmanogepix to Olorofim, which is pretty small spectrum, but has excellent activity in this small spectrum against some filamentous fungi, specifically against Aspergillus, but also Lamentosporus, Pseudosporium, and Fusarium, and against endemic fungi, dimorphic fungi like cocci, like histoplasma, excellent activity where it can really be a game changer and a significant improvement to what we have available now. Ibrexa, now we come to the more candida focused classes, Ibrexafungerp. This is a echinocandin-like new class of antifungals that can be given orally and has a spectrum of activity similar to echinocandins, but it's a new class and therefore it has benefits versus echinocandins in echinocandin-resistant strains where it still can be active. So mostly yeast infections, of course, also activity against pneumocystis and some activity against molds, but more as a combination partner than a single agent treatment. The good benefit of Ibrexafungerp that this is an oral drug, so it can be given orally and basically an echinocandin-like oral drug. I will not talk too much about encochleated amphotericin B. This would be an oral polyane, but currently development is paused, and I'm not sure this will be further developed. There is some problems with the drug concentrations that are very low, so it may not be a good choice for invasive infections. So I'll jump over that, but Rezafungin, of course, very importantly, now approved in Europe and the United States. A new echinocandin, it's actually an echinocandin, but it has a very long half-life, so it can be given once weekly, which has benefits in the management, but also potential benefits of very higher concentration early on after the initial infusion is given. During the first days, we have very high concentrations that may lead to earlier mycological eradication and may provide some clinical benefit. Oteseconazole, again, a drug I will mostly look over. This has really the focus on vulvovaginal candidiasis, has a very long half-life, has a big drawback, however, that it can't be given to women with reproductive potential. So it's more for older women with vulvovaginal candidiasis. In terms of approval, I mentioned Rezafungin is now FDA and EMA approved for invasive candidiasis. Ibrexafungerp is for vulvovaginal candidiasis FDA approved, as is oteseconazole. But all the other agents I mentioned are currently undergoing late-stage clinical development and are not yet approved for clinical use. Although there are some compassionate use programs, so in certain cases where you need them, you can apply to the companies to get these antifungals, and we have done this in the past successfully, for example, also for Fosmanogepix or Olorofim. So jumping now into the new antifungals, Fosmanogepix, basically, I mentioned very broad activity. Currently, there are two phase 2-3 trials running, one in invasive candidiasis and one in invasive aspergillosis. So you see both basically both are target organisms, so very broad spectrum of activity, novel mechanism of actions as it inhibits the fungal enzyme GBT1, which is fungal specific, has a lower potential for drug-drug interactions than the azoles and a wide tissue distribution, and big benefit also, it's developed as IV and oral formulation. You can see here maybe one of the things you will see is that Candida krusei seems like it's not included in the spectrum, but the good news is basically there's further research going into that, and this may go away, so this may also become green once we have more research. So generally, I think a great drug. Also, what's remarkable is that it seems to be very synergistic with polyanes, so it can be combined with liposomal amphotericin B, for example, for treating of mucormycosis. So this could be a game changer for some of these rare molds. It will likely be very broadly used once approved. So that's also a challenge for us ID physicians to make sure it's not used too broadly, right? Because we want to keep this drug around for a long time. We really need this and we want to keep it, and we don't want to use it for patients who don't need this drug. Basically, in terms of treatment, of course, the spectrum is broad. I think molds is particularly exciting. Fusarium species, that may really be the number one drug in the future for treating Fusarium, but also for mucormycosis in combination with a liposomal amphotericin B, etc., etc. Multiple potential indications. Of course, we need to await first the phase 3 trial results, also regarding, tolerability, drug-drug interactions, and then we need to monitor closely whether resistant develops. As mentioned, this is a drug where we already have a fungicide that's in use, and that may also trigger resistance that may occur in combination with the clinical use of the drug. So that's something we have to monitor. Next drug is Olorofim. It's also a new class, an orthomide that's currently developed. It's only developed as an oral formulation. So the ICU physicians within the audience may ask, how to use this in ICU patients. So there are studies that it can be used via the gastric tube in ICU patients. However, of course, it's acknowledged that, this is a drawback specifically for patients who can't take oral drugs. Basically, we have a completed study 32, a single-arm phase 2b study on Olorofim for probable or proven invasive mold infections and endemic fungal infections in patients with limited or no treatment options, so a salvage setting that is currently under review in a journal and will hopefully be published soon. This is basically the result from 202 enrolled patients presented at TIM 2023, where you can see basically that invasive aspergillosis salvage setting, I have to emphasize, we had a partial or complete response, about a third of patients, and all-cause mortality only 25%. So really very encouraging results. Similarly, with Lomentospora salvage setting, again with 42% partial complete response and the mortality of only 11%. So very promising antifungal for specifically molds, aspergillosis, Lomentospora, Scedosporium, also Scopoleuropsis, and also endemic mycosis, very promising for cocci, but also for other endemic mycosis. Currently, in terms of approval, there is a phase 3 study running, the OASIS study, which evaluates Olorofim versus treatment with liposomal amphotericin B in patients with invasive aspergillosis that can't receive azoles. So in terms of future use, we really think targeted treatment of invasive aspergillosis, including step-down treatment, as this is an oral drug, would be something where this drug can be used, and specifically also treatment of these rare molds caused by Scedosporium, Lomentospora, Scopoleuropsis, and endemic mycosis, as well potentially also chronic pulmonary aspergillosis, where this drug could be very promising. Oplaconazole, I mentioned basically this is an inhaled azole that has been developed with the goal to be an inhaled azole. So it's very small particle size that really goes in the peripheral airways and really brings a benefit versus other antifungals we currently use as inhaled agents that have not been specifically designed for that. Basically it has extremely limited systemic levels, so basically no systemic drug-drug interactions or systemic toxicities. That's why I think it's a very promising agent in terms of spectrum. Of course, it has activity against Aspergillus, pretty broad activity against Aspergillus, not covering mold, azole-resistant Aspergillus, of course. With Mucorales, we'll have to see how much it has activity. Generally, it's more thought to be an Aspergillus mold, Aspergillus antifungal. And anticipated use here is, of course, maybe combination treatment of invasive aspergillosis. So you add an inhaled antifungal to a systemic agent to further increase the concentrations in the lung in patients with invasive pulmonary aspergillosis. But potentially it could also be an agent for prophylaxis, for example, in ICU populations, non-neutropenic populations, where we know that Aspergillus grows for a long time in the lung only before it becomes systemic. So we may not need a systemic prophylaxis in some of these not super high, but still at risk patients. that are non-neutropenic, it may be enough to have this inhaled antifungal as a prophylaxis. And I'm specifically thinking, for example, patients on corticosteroids in the ICU. So, in terms of aspergillosis and the spectrum of disease we're seeing, of course, these antifungals I mentioned do have indications in different areas of the spectrum. So, on the one hand, we do have, of course, the more chronic versions of CPA or aspergilloma, where potentially we can use some of these antifungals as a monotherapy, even maybe, Ibrexa or Rezafungin as a monotherapy, Olorofim potentially as a monotherapy, and also Fosmanogepix. Versus when we go into the more invasive disease forms of IPA, tracheobronchitis, and disseminated disease, really Fosmanogepix remains as a mono treatment agent. I would also say Olorofim can be used as a single agent treatment. However, of course, it has only oral formulation. So I think in very traumatic acute disease, you would want basically an IV agent to make sure, you reach quickly levels. So it's more maybe a combination treatment in the initial primary treatment of aspergillosis. And for Rezafungin and Ibrexafungerp, as well as for the inhaled antifungals, of course, more a combination agent in acute invasive aspergillus disease. Immunotherapy, I think that's also an important topic, and there are currently some trials looking into that. So we may not only want to attack the fungus pathogen, we also want to basically work on bridging or on reducing the immune defects in our immune system that allow the fungal pathogen to become a pathogen and basically cause disease. And there is some trials now ongoing with recombinant interferon gamma, which is evaluated as prophylaxis in patients with chronic granulomatous disease. And may have also other indication if this trial is successful, and also natural anti-aspergillus antibodies or BTX3 that are currently evaluated for tackling IgG deficiency and B-cell suppressions in patients in the ICU. So definitely a topic of great interest, and maybe in the future we will treat mold infections with a combination of at one hand antifungal treatment, but also immunotherapy. Now moving over to Candida. So basically, we do have a number of promising future treatments for Candida infections, specifically here mentioning Rezafungin, Ibrexafungerp, and also Fosmanogepix, which all have a very broad spectrum against Candida, including Candida auris. So you see here that all of them basically were evaluated, at least in a number of patients with Candida auris infection as part of their primary trial. Ibrexafungerp had, for example, a specific phase 2b trial that focused only on Candida auris, which will also be presented at ECCMID 2025, the results. So keep your eyes out for that. Overall, all of them basically do have promising activity for Fosmanogepix. We definitely need more data because the trial was terminated due to COVID-19. So there we need more data from clinical trials, but potentially all of them could be active against Candida auris. So starting off with Rezafungin, basically key properties is that it has this structural modification from anidulafungin, which increases stability and resulting in these unique chemical and biological properties with a very long half-life of about 130 hours. And this also results in this front-loaded plasma drug exposure with very high plasma drug exposure early on during the first days after administration, and which may also be of benefit early on and may help to eradicate, for example, a Candida pathogen from the bloodstream faster. Tolerability, very good, very much comparable to echinocandins. And this is what I mentioned in terms of mycological eradication on day 5. There indeed, while overall this was performing as good as caspofungin for treating candidemia and invasive candidiasis, we had a faster mycological eradication of the pathogens, so blood cultures turned negative faster with Rezafungin versus caspofungin. The drug is currently also evaluated in another phase 3 trial, antifungal prophylaxis during allogenic stem cell transplantation. So also there, it may be a promising drug, with activity against Candida, but also pneumocystis, and also potentially prophylactic activity, of course, against Aspergillus species. So maybe an agent that, solves the matter what to use during the early phases of allogenic stem cell transplant as a prophylaxis, and we have to await the trial results there. Of course, this drug is now approved, and in the very recently published Candida guidelines from the ECMM, ISHAM, and ASM, published really, I think a few weeks ago, it already has a A1 recommendation, Rezafungin, you see it here, for treating in candidemia and invasive candidiasis. So definitely one of the indications is treatment of candidemia and invasive candidiasis. Given the benefits it has, it may also be a very good drug specifically for long-term treatments. For example, Candida endocarditis, which we may need to treat for a long term, but also treatment in some special populations. There has recently been a review I want to highlight here in Journal of Infection that highlights the potential of Rezafungin in different special populations where antifungal treatment is challenging and may indicate, that this may be a drug that brings us benefit there. Finally, Ibrexafungerp, it's, an echinocandin-like, but new class, the tritopenoids, basically, that is already approved in the US by the FDA for the treatment of vulvovaginal candidiasis, but currently undergoing a phase 3 trial, the Mario study, for step-down therapy of candidemia, basically run versus step-down with fluconazole. And there is already data from a large phase 2b study, the first study that will also be presented at ECCMID this year that has been finalized. Basically, it's a phase 2b/phase 3 study, single arm study, basically for salvage treatment that showed very promising result for Ibrexafungerp. So definitely a drug, an oral drug with, echinocandin-like properties that will be very interesting to have, and will give a big benefit for management, specifically or step down therapy, but also long-term outpatient treatment of, for example, fluconazole resistant Candida infection. Altogether, of course, many new antifungals. We always have to think which agent is also active in which organ. So not all agents go into all organs. Specifically, there's still the problem of lack of penetration into kidneys and urinary tract. So for, kidney infection, kidney fungal infection, that's still an issue. Renal fungal infection, where we don't have, that big solution yet. But nevertheless, I think the future looks bright in terms of treating fungal infections. And if you're interested in more details, I can basically hint towards our reviewing clinical microbiology reviews. And yeah, happy to be able to present you this presentation and looking forward to your comments and likes.